I'm Matthew Sloan, and thanks for joining us on the Joint Replacement Podcast. Today's guest is Dr. Keith Connolly, a fellowship trained orthopedic surgeon specializing in hip and knee care. He practices at the Advanced Center for Orthopedics and Plastic Surgery in Marquette, Michigan, where he focuses on helping patients restore mobility, reduce pain, and get back to the activities they love. With advanced training and a commitment to cutting-edge techniques, Dr. Connolly brings both precision and patient-centered approach to every case. Today, we're diving into his expertise, his journey in orthopedics, and what patients should know, particularly about partial knee arthroplasty. So thanks for joining us, Keith. And I just wanted to ask you a little bit about your practice, get your background. What led you to specialize in hip and knee replacement?
I had a little bit of a different career to start. I was actually a submarine officer before I went into medicine. Did that for a number of years. And when I first started thinking about going into medicine, I went and watched a hip replacement, and I was sold right away before I ever started medical school. I was like, that's what I want to do. That's what an awesome experience to be able to use your hands and power tools and all this and reshape somebody to get them back to walking. And that, so from that point on, I was just set on going into orthopedic surgery and specifically into joint replacement. And I started on that path quite a long time, even before getting into medical school. So
Very cool. And then how did you decide now that you're in practice, how do you decide who's a good candidate for a joint replacement?
well, I think you have to listen to the patient and find out what their kind of goals are and where they're at in this process. Um, but I think like most of us, when we're talking to patients, it's giving them the options that we have. So the conservative treatment options and the surgical treatment options. And the function of the patient is not always really well correlated with how advanced their arthritis is. And so you can have some patients who do not have really advanced arthritis, but have been through all the steps and all the things that we have to offer for conservative treatment. And those are excellent patients for joint replacement too, just as much as somebody who's got really severe arthritis and really limited function. And those patients that there's really just not much we can offer them from a conservative treatment anymore. Those are patients that are better off just talking about what the options with surgery are and how much that can improve their quality of life.
Yeah, absolutely. A question about your take on different surgeons. So, what do you think separates a good surgeon from a great one?
I really like that question. There's a few things that really separate a great surgeon, and I think it has somewhat to do with the person themselves as well as what they've been exposed to, their experience. I think one with the person, I think there's a lot of patients who will think people are great surgeons or great doctors regardless of what their technical ability is, and I think that's really actually an important asset to being a great surgeon. So being able to build a relationship with a patient, to be able to listen to them, and really to be able to earn their trust. So connecting with them, and with earning that trust, being able to provide them the service that's in their best interest. So really having the patient's best interest in mind. And some of that goes back to just talking to the patient, being able to communicate with them. So when I first talk to a patient, I don't really say, how is your knee or your hip? We're not talking about that at first. I just want to know, who are they and what do they like to do and what are they trying to achieve? And that helps to guide our conversation later. One thing is being that person who cares for your patients. And where I work, it's a really small community, so I can't go to the store without running into a handful of people that I've taken care of. So I'm really
Right.
invested in the people that I see. Um, and then the other part is the experience that surgeon has had, and some of that goes back to your training and your level of training. So what you're exposed to as a resident and as a completing a fellowship, and just the amount of those cases, the number of experienced surgeons that you've had to work with, how much you can kind of cram into your fund of knowledge to be able to apply that in practice, as well as your own volume, how much experience you've had and dealt with every sort of situation. Um, and when you have somebody who's able to pick up all those different pieces from each experience and assimilate that into your own technique and practice. I think that's what I think that's how we define great surgeons from good surgeons.
Yeah, absolutely. Are there things that you take in your practice that you think back in your train? We trained together at Penn, and then you did fellowship at Rothman, also in
Mhm.
Philadelphia. Are there
Yeah.
things that you pull out on a regular basis that you think, I learned this at Penn or I learned this at Rothman?
Yeah, I mean, I think each of my procedures is just a conglomerate of different pieces of other surgeons' techniques that I felt are the best part of each kind of step in that procedure. And just being able to hear multiple surgeons take on things and assessing things and talking to patients and examining things in the OR and I think from it was probably at least a dozen or 15 really experienced surgeons that I had the pleasure of learning from through those experiences. And if you can take the lessons that those guys learned over the course of their 15, 20, 30-year careers, if you can take those lessons forward with you rather than learning them all over on yourself on your own through your own experiences, then it's a lot easier to start off at a higher level to begin with. Yeah, so I definitely think that part of that training that we had together with multiple really great surgeons at Penn, helps to get us to where we are today.
Yeah, absolutely. So here's questions I'm sure you hear all the time. I hear them every day in clinic, but basically questions patients want an answer to when they're when they're trying to get some guidance on joint replacement. So the big one I hear all the time is how long does a joint replacement last? What do you tell folks about that?
So for the most part, I say is really should last the rest of your life. I don't really care what age you are to begin with. The durability of polyethylene nowadays, the evaluations of wear rates with highly cross-linked polyethylene or ceramic bearings and hips, those are so low. And especially when we are looking at uncemented technologies with fixation, um, I think we've really gotten to the point that a well done joint replacement, something that's um, done by somebody experienced, and then really should, for the most part, last the rest of their lives.
And when do you tell a patient it's the right time to have surgery?
I think that varies. For the most part, a lot of times we say you'll know, but sometimes they do need a little bit more guidance as far as when is that right time. And I look at how long other conservative treatments have been lasting for them. Sometimes when it comes to knees, we look at what their motion's been doing, and I'm pretty critical about measuring everybody with a goniometer at each visit and keeping an eye on that. And if that's starting to really decline, then we really should start thinking about maybe this is the right time to intervene with surgery before we get to the point where we can't get back to where we want them to after surgery. So it's a conversation, and I really don't look at things like age so much as a factor. I really don't think there's a right or wrong age for surgery anymore. So even octogenarians or above, when they can't enjoy their life and get out of it what they want, then I think they're, as long as they're otherwise medically fit for it, they're a good candidate for surgery.
And how about what is recovery really like from a joint replacement?
So I think recovery has changed dramatically in the last 10, 15 years, and even I think almost on a yearly basis, we find things that we can do to make that recovery better. I think, from my experience, I think partial knees and hips look very similar in their recovery, and for the most part now, it's pretty quick. So they're really off of their assistive devices in pretty short order most of the time. Within a week, I would say, and really off of kind of narcotic pain medication when they're using it within that time frame as well. And then they kind of will have a little bit of some ups and downs as we start doing more, and we still have inflammation that's hanging around for a while, but they usually tend to progress pretty quickly over the order of the first few weeks. I think total knee replacements are a little bit more challenging, but out of the advances recently in improving that recovery, I think that has changed dramatically. Even though I think they have a harder time in that first week or two, I think that experience now is still drastically different than even 5 years ago, just with with use of some different medications, with utilizing steroids or NSAIDs. I use intraosseous cocktail now, which I think has helped out quite a lot. Use minimal use of tourniquet, and I think that also somewhat helps. But for those patients, I think they typically do use an assistive device for a little bit longer. And of course, the most important thing is for everybody, you want to be safe and not fall. And people start off at different functional levels. And so not everybody's going to look the same, but using a walker for a week or two after a total knee replacement and progressing is still, I think, totally acceptable. And by the time I see them back, usually at 6 weeks, I think the vast majority of them are back to at least doing most of their routine activities.
And how about when patient wants to know, when can I get back to tennis or golf or skiing, those sorts of activities? What do you usually tell them?
So I don't restrict anybody with any joint replacements from doing whatever activity it is they want to do. I want to, for uncemented technology patients, I want to make sure that we have ingrowth of their components. And for things like running and tennis, I'll typically ask them to wait about 12 weeks for that. I think they can do other things much sooner, but when it comes to running or activities that involve really hard pounding or running, that's typically what I recommend. For things like golfing, I'll usually let them get back to doing some like chipping and putting after our 6 week visit and then progressing to more long drives about 4 weeks or so after that. But most patients, I will say somewhere within 2 to 3 months, you should feel like you're able to start on some of those activities and to just kind of let their hip or knee be their guide as far as what they're comfortable doing and progressing.
And if you can think of it, what would you tell a patient is the biggest mistake that a patient might make after surgery?
Well, I think for knees, in my opinion, I think it's really important to stay on an anti-inflammatory for a month afterwards. I think if you feel well and you stop, that'll be a little can lead to a bit of a backslide. And even if you feel like you're doing okay from a pain standpoint, I think it's helping you out more with regaining your range of motion. I think that's an important one. And the other thing I think, and one thing I really try to emphasize at every point of contact that I can is if you have a question about something, if you're concerned about something, call the office. There's always somebody on call. You don't want to go to the ER as like your first thing when you have a question or a problem with
Yeah.
your hip or knee because your ER, your primary care doctor, they are not trained to take care of this and manage whatever is going on post-operatively. So really contacting your surgeon should be your first choice when you think of something. And there's really no question or concern that you have that we're not absolutely happy to talk to you about and answer. There's nothing too small that we're not willing to address. And that's a big one is just contact your surgeon. If you don't think something's going the way it should, that should be your first option.
Yeah, that's a great point. I know I'll see a patient and they'll say, "Oh, I saw my primary care doc because my wound was looking a little funny a couple weeks ago and he put me on antibiotics." And I'll say, "Oh,
Yeah,
I wish I had known about that a couple weeks
right.
ago so I could have given you some guidance."
Yeah,
But
exactly.
that is a good one. I want to shift focus and hear your insights on where you think the field of joint replacement is heading in the future. Are there any advancements that you're really excited about, things that are just on the horizon?
Yeah, I think one thing that really hasn't we haven't moved the needle on a lot is joint infection, and it's still very small, but I do think there's going to be something in that realm that will take that down from around 1% to I hope much even less than 1%. And I think we do a lot of things with trying to optimize patients ahead of time. I think it's a much more important part of arthroplasty practice nowadays than it was maybe in the past. But I think there's going to be some things that come along with implantation and devices that will hopefully be able to take that down too, because we all know that's a really troublesome complication and one of those things that I think will have the opportunity to make better in the future. And then I think with the rise of joint registries and with AI, I think there's going to be a greater ability to analyze things and move research and outcome evaluations forward at a faster pace. So I think we're going to be able to find things that do finally separate outcomes and those variables and continue to make this a really great experience for everybody.
Yeah, absolutely. How about thinking even further, 10, 20 years down the road? What do you think a joint replacement experience is going to be like for a patient?
I think it will, if you just look at the last like maybe 5 years or so of what's happened in joint replacement, really going from predominantly an in procedure to an outpatient procedure, and just how rapidly that's changed. I think that's going to somewhat continue to the point that we think of doing some of these things more like we used to think of doing in arthroscopy, these kind of very relatively minimal interventions. So I think we'll probably get to that point where this becomes like a few day event for a lot of people. And I think looking like much further out in the road, I think eventually we'll find some biologic interventions with osteoarthritis that I think will really change the nature of what we do as a practice.
Yeah. Yeah, I get that question all the time, but PRP, stem cells, where are these things at? I think my
I don't think it is the PRP and stem cells, but I think that there's things that we don't even haven't even scratched the surface of intervening in that the kind of the process, the genetics behind it that will eventually really move the needle on how we treat arthritis.
Yeah, I feel the same way. I think most of the people who are getting into something like that at the time where they're thinking about a joint replacement, the arthritis is already so far gone that it's tough to
Correct.
rewind the
Yeah,
tape.
I think this will be many decades in down the road, but I think it will be getting to intervene on things before it ever gets to stage 4 arthritis.
Yeah. Yeah, exactly. I wanted to jump into the rapid fire segment and just go through not controversies, the things that are undecided in the joint replacement world, and just see what you do in your practice. One, what's your typical follow up schedule for seeing patients after surgery?
So we see them back at 2 weeks. That's often a mid-level. That's seeing them at 2 weeks. I see them back at 6 weeks, and then if they're doing great after that, it's 1 year for patients. Typically, it's with if I think that they need more observation of their progress with motion, I'll typically see them back somewhere 4 to 6 weeks after that.
Yep. What's your cutoff? If you were thinking about something like a manipulation, if someone's on the stiffer side, when do you try to get that done?
It does vary, and one of the reasons that I try to be very critical with documenting what their range of motion is ahead of time is because I think it's so predictive of where you want them to be after surgery and what the capacity to achieve is. So really, it's relative to where they started, and I would say if they're within about 10 to 20% of that, I'll give them, I'll typically do some steroids and some anti-inflammatories after that and give them a few more weeks to work with therapy and see if they can bring that up to it. If they're really far off, and particularly a lot of times we'll see this, I think younger patients will be more likely to be in this category. Not everybody, but I think they have a more robust inflammatory response at times. And so if I think they're really far off, I won't necessarily wait till they're close to 3 months to do that. But we're still talking about 2% or less.
And you touched on this a little bit, but what's your preference for cemented versus cementless?
So I've done more uncemented and really talk about knee replacements where we use cemented technology more. So I've gone to using more uncemented over the past few years as that technology has shown greater promise. And I will typically use it in just about everybody who's under 65 as long as their bone quality is good. And then for females, somewhere up to about 70, for males up to about 75, and really balancing this risk of potential early failure versus late failure and trying to find where that medium is and expected
Mhm.
longevity to want our implants to last more than 30 years. And that's where we just we don't have the data from what our cementing techniques are with modern implants just because of limitations in the in follow-up time periods now.
Yeah. And how about hip approach, posterior versus anterior? Do you use a table?
I do all anterior and I do off table, so standard OR tables.
And we'll probably get into this a little bit more, but what's your breakdown for partial versus total knee replacement in your practice, if you had to give it a rough percentage?
It was about 25% partial knee replacements. I try to I try to look at every patient and say, what would I want to do if this were my knee? And for the most part, if I think they're a good partial knee candidate, I prefer to go over why that is and what the benefits and risks with each are. And so I do try to tend to favor partial knees for patients who are good candidates for it.
And when you do a partial knee, I don't do quite as high a percentage as you do. I always talk to my patients on the consent, partial versus total. If I get in there and there's more arthritis than I'm expecting, we always have a total available because I don't want to put a partial in you if the other side
Mhm.
looks bad. I actually don't think I've ever had to convert during the surgery. Is that a similar experience for you, or have you had conversions during the surgery?
I do more, and I would say about twice a year, I'll find a patient that I say, I don't think a partial knee is going to be the right answer for them. And I don't routinely get MRIs for patients operatively, and I did about 90 partial knees last year, and about two of those got converted. I think that's a pretty good ratio for being able to assess just on x-rays preoperatively. But generally, I want to do what I think is going to last the patient the rest of their life without another surgery. And so if I open it up and I say, this didn't look like what I expected on their x-rays. And I talk to them, that's just part of my conversation ahead of time. I'm going to open your knee up and we're going to look at it. And if I don't think that's the right thing for you, I'm going to do what I do think is the best thing. Everybody, I think, agrees with that. Do what you think is going to be the best long-term solution.
Yeah. How about robotic versus manual versus navigation? Are you using any of that technology?
So I do all conventional for hips and knees now. And we have Rosa at our surgery center, and I started doing that for a little bit, but I actually feel like at least in my own hands, I think I'm doing the best job for my patients with my conventional technique.
Yep. Yeah, I mean, there's certainly pros and cons. I know the the thing that's out there about robotics is you do it quicker if you do it the conventional way. What's your take on the amount of time that you spend on a case versus what you were doing with Rosa? Were you finding that it was taking you longer to do the surgery and you still weren't as happy with the outcome?
It definitely takes longer, and there's very every study that you look at, that's the one variable that's always consistent. It does take longer, not that I think that's the most detrimental thing, but it's important. The more time we have things exposed, the greater chance we have for things like contamination. But for me, I feel like I'm very meticulous with what I do and all my cuts and measurements and everything, and I have my staff very well trained for us to be able to make those adjustments with balancing the knee and just moving through all those steps very methodically and quickly. And I'm ultra conservative on my cuts. I almost always am going to be recutting the tibia at least once because I always want to end up in that. I use a Zimmer Persona. I really like to be in the 11 to 13 millimeter range where I have that fidelity and I can be very confident that I'm not one size too big or too small, and I have that 1 millimeter adjustment to make with my final insert. And for me, I felt like I wasn't getting the result with the cuts exactly where I wanted them with the robot. It just wasn't exactly down to the millimeter of where I wanted that. And so for me, that was just like I couldn't justify a benefit of going over to that. So that's why I do what I do, and I do a very high volume, and I think I've just gotten to the point where I think I'm doing the best, most reproducible job with my cases the way that I do it.
Yeah. And how about outpatient versus inpatient? About what proportion of your patients are outpatient?
I'm probably above 95% outpatient right now.
Oh, wow.
I maybe may have one or two patients a month that might stay at the hospital, but almost all outpatient. In fact, I only operate at a place where we would keep patients overnight, usually once or twice a month, and they're otherwise all at outpatient facilities, essentially.
Yeah, that is definitely the way that things are heading now, that it's not an inpatient only procedure. How about prehab? I get asked about prehab a lot. Do you ever prescribe prehab? Do you have a home exercise program you recommend ahead of surgery? What's your take on that?
I do a little bit of both. I have a book that I've made. There's an exercise program in the back of that book that I'll give patients ahead of time that they can work on. If I particularly lean towards prehab for patients that I feel don't have the motion ahead of time that I want, and I think I might be able to gain some motion before surgery. I think that 4 to 6 weeks of maybe working with a therapist would be good. Or if they feel like they need a little bit of extra, maybe conditioning before surgery. So I don't routinely prescribe prehab, but I think there is certainly a place for it. And if patients want to get established with a therapist and learn some of those things ahead of time, I think that's also a good idea.
About your closure for hips and knees, what do you use on skin? What are patients going to see when they take the bandage off?
We do a 3-0 monocryl subticular layer for the suturing, and then on the dressing, I typically do a silk dressing and then a Mepilex over that. So they'll have the kind of the larger waterproof barrier that we typically leave on to their follow-up visit. And the silk, which has some properties that I think additionally promote healing, we'll typically leave that on for another 2 weeks even after that. And really have had very minimal wound issues and some very hearing incisions now using that technique.
And you take the silk off in the office, or is that something they can take off at
No, I
home?
usually tell the patients to take it off 2 weeks after we remove their Mepilex dressing.
Nice. And how about what is your typical DVT prophylaxis? What do you use to prevent blood clots after surgery?
We do baby aspirin daily for most patients without a lot of risk. And I think the most important thing, and the thing that I really harp on with them before surgery, is that the critical part of preventing a DVT is moving, is getting up and walking. And early mobilization, so getting these patients up an hour after they're out of surgery and ambulating, encouraging them to get up every hour and at least take a few steps. I think that's been the real key difference, managing their pain after so they want to be able to move and walk. And the DVT rates are just so incredibly low nowadays.
Yep. And how about post-operative antibiotics? How often are you using them? Are there certain patients that you prefer to use them for?
Very infrequently prescribe post-op antibiotics. I will in very high risk patients with typically if their diabetes is controlled with an A1C like less than 7, I don't. But if it's somewhere between 7 and 7.5, just because we can't really optimize them any better, or they've had a history of other problems with infection in those patients, I'll typically put on a couple weeks of an oral antibiotic.
And you mentioned this before. It sounds like your patients are getting off narcotics fairly quickly. But what's your typical pain management? What percentage of your patients do you think are actually not using narcotics after surgery? And are there any particular medications you've found have been really effective?
That's a great question. I wish I had like hard data on who doesn't really use any narcotics after surgery. I talk to almost all my patients, typically post-op day 3. Afterwards, I'll call them. And the majority by post-op day 3 are not using a lot, if they are still using that. My guess is that it's probably around 20% that don't really use any after what they get that day of surgery or so. We do Tylenol, 1,000 milligrams every 8 hours. We do meloxicam daily, typically 15 milligrams for most patients. The baby aspirin, as we mentioned. We do tramadol a lot for unis, and partial knees, and hip replacements, and oxycodone usually for total knee replacements. I have just recently started using Journavx, but only in a couple cases, but that will probably fit into our postoperative regimen to try and replace some narcotics. Um, and then we'll sometimes use steroids, I think, as we need. I prefer to probably use a steroid rather than to increase a narcotic if I think somebody's struggling with pain. Um, and just the ability to limit the side effects from using opioids is also important. Patients really don't like having nausea and constipation and the confusion that occurs. I think having a good multimodal approach, as well as using intravenous steroids and intraosseous cocktail during surgery, is, I think, helpful.
Yeah, absolutely. And how about any contraindications or hard stops for surgery for you?
So probably my only hard stop is smoking. I don't operate on anyone who's still smoking. I try to get diabetics to an A1C of less than 7 preoperatively and work with their providers with that unless they I really try not to operate in any way with an A1C over 7.5. BMI is pretty variable for me. I typically try not to or try to get anyone under 45, but some of it depends on a little bit of their body habitus, where they carry their weight, and I think that's more important in my practice with hips, and really just making sure that it's something that I feel is technically feasible, that I can adequately do a good job, especially with kind of getting exposure to the femur. There are just some very large people who carry a lot of weight around that area, so it's a little bit patient specific at times.
How about patellar resurfacing for your total knee replacements? Are you leaving the patella alone or do you resurface typically?
I'm a selective resurfacer, so I probably resurface about 20% of the time, maybe. I look at I think the lateral facet, where I try to pay attention to a lot of times with the majority of knees are varus, and they'll have that wear more toward the medial or inside portion. But as we correct the deformity, that's going to change how that tracks. But lateral wear, I think, is more concerning for me. So in general, if I look at it and I think it's and the thought crosses my mind, I'll probably resurface it. But I certainly prefer to leave the native kneecap for most patients when I think it's not indicated.
And you talked about this as well a little bit, but are you using a tourniquet? Do you put a tourniquet on? How do you decide if you're going to use that for a patient?
So I do intraosseous cocktails for everybody. I put it up right at the beginning of the case while we're injecting, and I'll leave it up for a few minutes after that and then put it down.
And if you had to pick, what is your favorite surgery to perform?
I think a partial knee is my favorite surgery to perform. I think it's just one that has to be done meticulously and balanced within a millimeter, and I think it's a really beautiful surgery when it's done correctly. So I think that's my favorite.
We'll talk a little bit more about that here in a second, but I also want to get patients oftentimes anxious before surgery, totally normal. They're trying to decide on a big life decision. Should they go through a surgery? Should they live with it longer? What advice do you give patients who are nervous about surgery?
One, and I hear this all the time especially like in the holding area and stuff. I'm a little nervous, and I say, well, it's normal to be you're a normal person. It's a big intervention. And so there's nothing wrong with that. But we're here for a reason. We're here to get you to where you want to be with your life. And we know that we can't get there through other means at this point. That's why we're here and doing this. And I just emphasize that I'm there to take care of them, and I'm going to do the best job possible. And we've got a great crew who's been trained to do this. And this is what we do every single day in and out for lots of patients. And that they're in good hands, they're making the right decision.
Yeah, that's really great reassurance. And last question before we get a little further into partial knees. How would you recommend a patient, maybe they don't live near your area, maybe they do live near you. How do you recommend to patients who are thinking about joint replacement the best way to pick the right surgeon for them?
Yeah, that's a good one. And that's I think a tough question for anybody, even us, even when I'm trying to, somebody calls me and they live somewhere else and I say, how do I find this best surgeon? One of the things that I think really could be improved in all of medicine really is how do we give that comparison to patients and that data and feedback on surgeons. So I think the few things that we can look at is one, their training. And it surprises me still today that patients really don't look at who they're going to see sometimes and don't do any kind of research on them. But you can at least know if somebody is fellowship trained in whatever you're going to see them for, if they've had advanced training in that. And for the most part, in these days, there's really no reason not to see somebody who doesn't do exactly what you're going to see as their practice every single day. There's a reason that we subspecialize in things, and it's because if you do the same thing in and out every single day, you're going to be very good at it. It's a matter of repetition and experience, like I talked about earlier. So at least finding somebody who's trained in what you do, and that's what they focus on, and they do a lot of it. And then, of course, they can read reviews. For me, where I live in a very remote area. The city I live in is only about 20,000 people, but we take care of patients from a very large geographical area of about 300,000 people. On any given day, I have people traveling a couple hours from each direction for surgery. But in my community, word of mouth is everything. So we do very little advertising. I have no social media presence, but everybody talks to their neighbor about who they saw or had do their surgery. And so that's a really big factor in who people go to see. Um, so I think it's sometimes a tough thing to evaluate, but I think what you can look at is at least what reviews are, what their training has been, and what their focus and their practice is. So you don't want to see the jack of all trades. You want to see the guy who does exactly what you're doing. So you're gonna need to have done.
Yeah, exactly. All right, so I wanted to pull up this article that you shared with me. Did you want to walk me through this and how you think about this information and how it affects your practice?
So one thing that I like about this article, one of the reasons I picked it, is this is from Michigan. This is from our statewide registry called Marquee. We're really one of the only states that has this extensive of a database. And so essentially everybody who, is a relatively high volume surgeon, or really it's the facility. So if the facility does over 200 cases a year, they're really enrolled in this. They're able to be enrolled in this database, which I believe pretty much all of those are. And it's so nice because it compiles all this data and we get feedback on everything from implant usage to revisions, infections, the rates of complications. And so a really helpful thing in the state of Michigan. And if somebody goes to another surgeon in the state and has their knee revised, that gets put in this registry. So we get to capture a lot of data. And it's a really nice thing about one thing I really like about practicing in Michigan and being involved in this registry. And I think that there's a couple things that are in this study, but one is that this goes back to what I was saying previously. If you do something a lot over and over, you get better, and you're going to have better outcomes with it. And so this did show that as the level of volume goes up for partial knee replacements, the likelihood of revision goes down. But there's a couple things even inside of that are important. And one is that for most of these partial knee replacements, this has been over several years, the majority, like 60% of the revisions occurred in the first 2 years. And so that really goes to show you that they didn't do well, like right off the bat for these patients. And really for what that tells me is that the surgery itself wasn't performed. And I think knowing how to do this surgery and what it should feel like, what that knee should feel like and look like at the end of it, is so critical to having a great outcome. And if you're only doing a few of these a year, it's not possible to, I think, produce those results. And I think that's what it shows, is that if you have a lower volume, you're probably not getting great outcomes with these, and they're getting converted quite earlier. But I think even though there's definitely been shown that there's a higher revision rate, I'm on that graph to the left here, in one of these few dots out to the very far right side of that. I think in those situations, the longevity I expect is going to be very close to what our total needs are when we get out to looking at very long-term outcomes with these. And that's what really shows that in general, most patients who have either a partial or a total knee are not going to need another surgery in their future. And the ones that do, for the most part, it's early on. They don't do well very early on. And I think that has to do with technique and probably something to do with patient selection. But the other thing that I think I'm a little bit fortunate in my environment where I'm at, where I see my patients come back to see me because there's not anybody else around here. And there's a lot of other reasons that people can have a problem or have pain around their knee after surgery that have nothing to do with knee replacements. I see referrals all the time for a painful knee replacement, but most of those don't need a revision. It's not usually a problem with that prosthesis. But I
Right.
think the inclination for many surgeons might be that if they've had a partial and they're having pain, they need a total knee replacement. That's probably not the case for the vast majority of the time, but I think that's unfortunate. So you really got to be careful when you go to see somebody else if you're having some pain, and making sure that's not a soft tissue issue, or your hip or some other source, which is probably more likely than progression of arthritis if the surgery was performed.
Yeah.
Those are, I think, some key factors in this.
Yeah, and I think here's the information you're talking about, comparing the high to the low volume partial knee patients. The early revision rate was 3.6% at 2 years for the low volume surgeons compared to 2% for the high volume surgeons.
Mhm.
So definitely almost 50% revision rate, or half the revision rate. The other thing that kind of jumped out when you were talking about that increased early revision, it could be a technical thing. It could also be like yourself, you're thinking about every patient. Are you a good uni candidate? Are you a good total candidate? Your indications are probably better than someone who does it once in a while. People may be putting unis in patients who really aren't great uni candidates just because they don't have that acumen of picking out who they think is going to be the best candidate for that surgery, just without having that experience.
Yeah, it's patient selection is an important factor in it. But again, most studies will show that the function with a uni is superior to a total knee replacement. Forgotten joint score certainly much higher with partial knee replacements, and I certainly don't. Uh, I certainly feel like it's a superior outcome in the right patient. I think, and it's potential that one of the reasons that we don't have the great satisfaction with total knee replacements is that maybe that really wasn't the right surgery for that patient. That patient probably could have had a total knee replacement and done excellent, but because we have to do more intervention with that total. Everybody's got to get that tibial component in, and you got to be able to get that amount of exposure. And it's just more that is required of the knee to do a total, and it's just maybe just not the right answer for everybody. So I think doing the right surgeon for the right patient and the right technique is really important.
And how about just your breakdown of what types of partial knee replacements? I see patients all the time, they say, am I a candidate for a partial? There's different types of partials. Not every patient understands. There's a medial partial, there's a lateral partial, there's a patellofemoral. The medial partial by far is the most common done in the US. How's your practice split? Do you perform
Yeah.
patellofemoral and lateral?
So I predominantly perform medial, and obviously that's largely driven by the incidence of disease. So there's just are going to be medial versus less than 10% as far as lateral in being a candidate. And part of that also drives my own comfort with practice is that I really don't feel comfortable just doing a lateral uni a few times a year for that patient, because you just can't get the experience and volume with that. And then do you make a lateral arthrotomy? And now, what if it's not really a great candidate after you do that, or if they need to be converted? I think there's just some things with that uh, lateral uni that detract from it being a great option for a lot of people. I do very selectively do patellofemoral replacement, but that I think is something that we really just can't, just based on an ad, we can't guarantee always that's going to be the last surgery they need, because we're not addressing any kind of weight bearing part of the knee, and we don't know what's going to happen to that weight bearing part in 20 years. But that's a conversation that you can have with patients, and I think there are some good candidates for patellofemoral replacements, but they're relatively few and far between. But that's a procedure that, for the most part, we're really doing that procedure very frequently, resurfacing patellas all the time. I'm an anterior referencing surgeon, so I'm really doing that anterior referencing, anterior femur surfacing when I'm doing a total knee replacement. It's that same type of procedure. So that I feel like I do have the exposure and experience to be able to reproducibly do that very well.
You're thinking about a patellofemoral partial knee replacement. Is that a situation where you'd get an MRI to look at the rest of the knee?
I
Or do you?
usually do. I usually do, because I'm more concerned about what level of arthritis there may be that's not as evident on an X-ray.
Yeah, me too. I feel like every time I see a patellofemoral, there actually is, or I feel like there is more weight bearing arthritis in there than I appreciate on x ray. Any other parts of the paper in here that stick out to you, or anything else you want to touch on here?
I think we touched on key parts of that.
Right. So Thanks so much for joining me, Keith. Anything in closing that you want to mention to patients who are watching this?
I think if you are watching this, it's good on you for going a step above and beyond and learning a little bit more about what you might be having done and being involved in your care. Thanks for getting this information out there and hosting this podcast, Matt.
Yeah, absolutely. All right. Thanks, Keith. Thanks so much. Have a good night.
Yeah, as well.